surgery. And today we are our doctor here, and we are eager to have your lecture and to teach our doctor about cosmetic iris and also optical surgery. Thank you very much again for you come here to teach our doctor and really have your presentation today.
Thank you so much. Happy to be here.
Yes. Thank you. Yes.
Can you hear me in the back?
Yes.
Okay. Let me know if I need to speak up. It's a pleasure to be back here at Vietnamese National Institute of Ophthalmology, Vietnamese National Eye Hospital. This is my fourth visit here, and each time I come, I meet more and more new friends, and it's really a pleasure to be back in Hanoi and to see all of you again. I have 4 or 5 lectures on my laptop, and this evening in my hotel I will put them on the cloud on Microsoft OneDrive. And all of the residents and faculty will have access to these lectures. This lecture I will give today is an overview of oculoplastic and eyelid surgery. Now, if you look at this QR code, if you take a picture of it and save that picture, later that will take you to a link. It will take you to a link right now of a folder. And tonight in my hotel, I will put all of my lectures in that folder. Right now, there's nothing there but an empty folder. But tonight, I will put this lecture and all of my other lectures in that folder. So any of the residents, anybody that wants to see these lectures later, you will have access to them. The lectures are in Keynote format, and Keynote is for the Apple Macintosh, which is this. I also put the same lectures in PowerPoint and PDF files. So if you wanted to look at them on a smartphone, the PDF is a much, much smaller file. It does not take up as much space. So you could keep that as a resource or a reference. But today we're going to focus on this lecture, but you will have access to all of them, and I will put them in the folder later this evening. Today we're going to go over eyelid surgery and reconstructive surgery, eyelid and periocular surgery. We will cover all of these topics, and one by one, I will go through these topics. First, we'll start with eyelid lesions, simple excisions, wedge resections, and more complex reconstructions for eyelid tumor and eyelid lesion excisions. We all see simple lesions in our office every day. Most of these can be excised just within a few minutes. Local anesthesia, forceps, scissors, we excise the lesion. If it looks suspicious, I always send it to pathology. If it's just a simple papilloma, I do not always submit that for pathology. But if it looks suspicious or I need to know the pathology, I will put it in formalin and send it off. But these simple excisions often just require excision, very light cautery of the excision site, and often you do not even need any sutures. And I'll just show you some examples of some of the simple benign lesions that we see in ophthalmology. One of the most common is the squamous papilloma. Sometimes they're called a skin tag, or a fibroepithelial polyp, or acrocordon. They have many names, but they're benign squamous papillomas. And these have been associated with some systemic conditions, and if you see a patient with dozens or hundreds of squamous papillomas all over their face or all over their body, sometimes that is caused by HPV, human papillomavirus. And some of those patients are at an increased risk for squamous cell carcinoma later in life. But these are very common. In some studies, up to 50% of adult patients do have at least a few papillomas. So they're very common. They have a classic appearance. They're usually elongated. They have little tiny villous structures on them. If you look at them through a slit lamp microscope, they all look fairly characteristic. Some of them are very elongated and eventually can become ischemic and just fall off on their own. But these are the so-called squamous papillomas. When you see a cluster of many papillomas all over the eyelid, those patients are at a higher risk of carrying HPV, human papillomavirus. There are many different subtypes of HPV, and some of them are highly linked to papillomas. Other types of HPV are linked to cervical cancer, squamous cell carcinoma, and other conditions. But some of these can be larger and can be often observed in HPV and also verruca vulgaris. A larger lesion can be associated with HPV. Other lesions are called seborrheic keratoses. They sometimes are pigmented, sometimes they're not pigmented, but they tend to be flatter, and they're easily removed because after injecting a local anesthetic, you can often grasp the edge of it with forceps and use a 15 blade or a scalpel and gently peel them off of the skin. So they're usually pretty easily removed without much of a deep excision. Some of the seborrheic keratoses can be quite large, and it can become pigmented or necrotic, and sometimes can be confused with other lesions such as melanoma. And some patients have dozens or even hundreds of seborrheic keratoses all over their face and all over their body. And we usually don't remove all of them, we just remove the ones that are causing symptoms or are cosmetically objectionable. Another common lesion is called a syringoma. They tend to be round or oval shaped. They come in clusters. You'll often see them on the medial lower lids and on the cheek area. And these are thought to arise from eccrine cells and sweat glands. They have a waxy appearance. They can be associated with some congenital syndromes. And I've seen some patients that have just a whole cluster of these syringomas covering a wide area on the lower lid. Now, if a patient has a broad area of these syringomas on the lower lid, you sometimes have to be cautious not to remove all of them at one time. If you do too many excisions at one time, then during the healing phase, there can be some contraction of that skin. Then they can get a cicatricial ectropion or even a lower lid retraction. So if a patient has multiple lesions like this all in one area, it's sometimes safer to remove a few at a time. Remove maybe 4 or 5 lesions, wait 3 months for that to completely heal, remove a few more, wait for a few months and remove a few more. That's a little safer than removing all of them at once to try to avoid tightening of the skin and ectropion. And some of these can be quite extensive and cover the upper and the lower lids. These are called syringomas. They're benign lesions. Another benign lesion that can be associated with a pox virus is called molluscum contagiosum. And this typically has an umbilicated structure with a pit or a hole in the center, and they're very classic in appearance, and they can shed a virus. Often when you remove these, it's best to excise them and lightly cauterize the base beneath them, and that will usually eliminate that lesion. It also decreases the shedding of the virus, so that decreases the chance of having more of these lesions in the future. These are simple, various types of simple nevi. A nevus is a benign lesion that contains increased melanocytes. Some of these can later convert into melanomas, but that is rare. And some of these are benign congenital nevi. These do have a higher incidence of conversion into melanoma later in life. Dysplastic nevus with an irregular border or mixed colors or some strange ulcerations or bleeding or vascular changes. These are called dysplastic nevus, and they have a higher incidence of conversion into melanoma and should be excised. There are several vascular lesions of the eyelid. Most of these are capillary hemangiomas. Some of them are cavernous hemangiomas. I'll show you some examples of these. They can be elongated, they can be flat, they can be subcutaneous, they can be associated with congenital syndromes, such as Sturge-Weber syndrome. This patient had a very extensive Sturge-Weber syndrome with a big capillary hemangioma that extended up onto the scalp, across the brow, and down into the cheek area. He covered it with cosmetic powder just to block the view of it, but he had this evoked in the past, and then I saw him and it was causing a secondary ptosis, so we did some additional debulking and ptosis surgery to help with his drooping and his laxity of his upper lid. Another common lesion that is considered benign in most cases is an angiofibroma. These can be associated with a syndrome known as tuberous sclerosis, also with multiple endocrine neoplasia type 1. These can be excised and debulked when there are many of them. Often when there are this many, you can only remove a few at a time. Now, xanthelasmas are common in patients with hypertriglyceridemia, and they contain histiocytes that contain lipids. They can involve the upper lids or the lower lids or both. They're typically on the medial aspect of the eyelids, and they often will cause a yellow deposit on the medial aspect of the upper lid or the lower lid. And when we see a patient with this condition, we want to check their lipid profile, check their cholesterol and their triglycerides. It's actually more associated with hypertriglyceridemia than hypercholesterolemia, so make sure you check their triglycerides. There are many different types of cysts of the eyelids. Some of them arise from sweat glands or oil glands, sebaceous glands. So I'm going to show you some examples. These are chalasia and sebaceous cysts. And also if it's right on the lid margin, we call it a stye or hordeolum. And these are different types of sebaceous cysts. They arise from the glands of Moll on the lid margin, or if it's a chalasia on it, it arises from the meibomian gland. Sudoriferous cysts arise from sweat glands or Moll glands, and they're also called hydrocystomas or cystadenomas. And these are very common. They sometimes are solitary with one cyst, and sometimes there are dozens of them. I've seen patients that have had as many as 60 of these cysts on all 4 of their eyelids. When it's just a few, I will inject local anesthesia in the office and remove it right in the office. If it's 50 or 60, then I will take them to the operating room and they'll have some intravenous sedation. And it's too painful to inject that many lesions without sedation. This patient had multiple sudoriferous cysts or hydrocystomas across all 4 eyelids. This is a conjunctival inclusion cyst, and these can be large or small. I've actually seen these cysts that are mobile. They're subconjunctival, and they've become isolated. And if you push them around with a Q-tip on the eye surface, they can actually move around in the subconjunctival space. So some of these are actually mobile and not attached to anything. Neurologic or neurogenic tumors include neurofibromas. We've seen 2 or 3 patients just in the last few days with neurofibromatosis. And they tend to get either massive tumors like this, or they can get more diffuse, soft, spongy tumor that infiltrates the eyelids and expands and stretches the eyelids. So these patients, as the patient on your left there, get severe laxity of the upper and lower lids. So they often require surgery to not only debulk the tumor, but to tighten the eyelids, sometimes to lift the lateral canthus, sometimes correct an ectropion or a ptosis. But I've seen many patients with neurofibromatosis. These tumors are diffuse and infiltrate skin, dermis, muscle, orbit, all layers. So you really can't completely excise them. You have to just debulk them, reduce the amount of tumor tissue there, and address any ptosis or laxity of the eyelid. And they can be quite extensive. They can extend from the forehead, through the brow, through the upper and lower lid, and down into the cheek, and sometimes require a flap to debulk them. Actinic keratoses, also called solar keratoses, are considered a pre-malignant type of tumor. They often precede development into a squamous cell carcinoma. So if you see an actinic keratosis, it's usually caused by ultraviolet radiation and sunlight, causes damage to the skin. That will cause some ulceration and some crusting of the skin, and these can later turn into a squamous cell carcinoma, so it's best to excise them. A keratoacanthoma, or a cutaneous horn, is considered in transition between an actinic keratosis and a squamous cell carcinoma. And these are now considered by ocular pathologists and dermatopathologists to be a very low-grade squamous cell carcinoma. So keratoacanthoma is now considered a low-grade squamous cell carcinoma and should be removed. Basal cell carcinoma is the most common one that I see in my practice of all of the skin cancers. It can become quite extensive and spread into the orbit and into the sinuses and into the skull, but it usually does not metastasize to other parts of the body. It can metastasize, but it's very, very rare to metastasize. Now, sometimes a basal cell carcinoma can be quite extensive. I saw this patient during my fellowship in oculoplastic surgery. He had received an exenteration of his right orbit 10 years earlier. Then he was lost to follow-up. He did not come back. Well, he finally came back, and this tumor had recurred, and it spread into the nose, into the ethmoid sinuses, and into the other orbit, into the skull base, and wrapped around the carotid arteries and the cavernous sinuses. So not at all resectable. And back when I saw this patient, the only treatment available really would be radiation therapy, and they're not very sensitive to radiation therapy. So this would be a terminal condition when it's growing into the skull base. Nowadays, we do have other options, and I'll show you some of those other options in a little bit. Another type of malignant tumor is squamous cell carcinoma. These tend to have a little bit different appearance and architecture than basal cell carcinomas. They can be more ulcerated, red. They can be invasive. They can cause pain in the face if they invade the nerves. They are known to travel to other parts of the body through perineural transmission. So you have to be cautious with squamous cell carcinomas. They can get into a nerve and travel along that nerve to another part of the face or the head. This is a patient I saw at the Veterans Hospital in Fort Wayne. He had undergone previous extensive excision of a massive squamous cell carcinoma, and then he had a pedicle flap taken from his back up to his face to cover part of the defect, and he had an orbital exenteration as well. So this patient is really a terminal patient, and his life was extended a while just by doing heroic surgery. Sebaceous carcinoma, these arise from the oil glands, probably the meibomian glands and the glands of Zeiss of the eyelid. And in my country, sebaceous carcinomas have a very high mortality. Now, when I was in Bangladesh several years ago, working with a doctor in Chittagong, he said, we see a lot of sebaceous carcinoma here, and it has a low mortality. So they tend to have different behaviors in different parts of the world. This is a lentigo maligna, or basically a melanoma in situ in the surface layers of the skin. These should be fully excised because they can convert into a deep invasive melanoma. This is a Kaposi's sarcoma. Back when AIDS and HIV was much more prevalent, these tumors were commonly seen in patients with immune deficiency syndrome. Now we're going to talk about some of the procedures for excision of these larger tumors. We'll start with wedge resections. When you see a tumor like this that's involving the lid margin and you're in the operating room, you want to take a marking pen and mark at least 3 millimeters beyond all visible margins of the tumor, at least 3 millimeters. And then if you have pathology available to do a frozen section, that's a good way to manage the margins. With a frozen section, you send your specimen off, and while you're doing your reconstruction, the pathologist examines the margins, and they call you back within about 30 minutes and say, your margins are clear, go ahead and finish your surgery. Or they say, I need another specimen from the temporal margin, or the medial margin, or the inferior margin. So that gives you an ability in the operating room to try to make sure all of your margins are clear before you close up. Now, in my country, we have some dermatologists that specialize in Mohs, M-O-H-S surgery, and they use a different technique where in their office, they will go back and forth 5, 6, 7 times and take little slices of tissue again and again and again. They go back and look at them under the microscope. They're trained as dermatologists, dermatologic surgeons, and dermatopathologists. So they do the excision and the pathology themselves in their office. That's called a Mohs surgeon. And I see referrals from them sometimes after they've removed a big tumor. They'll put a bandage over it and send it to me to put it back together. And sometimes it's just a small defect. Sometimes it's the entire lid and the medial canthus and part of the cheek. So it depends on how much tissue they remove that'll determine how much we have to reconstruct. But I'm going to talk to you about these larger excisions of larger tumors. You know, the basal cell carcinoma, if they're nodular, they're easier to remove. If they're more diffuse, like this one, you know, this tumor extends way up into here. It's not always obvious how far the tumor extends, but after you see many of these, you can get an idea as to how far the tissue extends, and you always want to mark beyond that. You want to take the tumor, send it to pathology, and get some answers as to whether you've excised it all. Once you excise it all and you're sure your margins are clear, then you begin the reconstruction. This was a large tumor excision sent to me by a Mohs surgeon. He had excised this massive tumor involving lower lid, medial canthus, nose, and the cheek, and sent it to me for reconstruction. And I'll show you some slides a little later on the reconstruction. Now, what happens when a tumor is not resectable? This tumor is not resectable. It's growing into his skull base. It's around his carotid arteries, having his sinuses. It's in the other orbit. So your options are radiotherapy. It's not a very good option. It doesn't work very well for basal cell. And also there are some new drugs available. They've been available since about 2012. And some people have even tried the antifungal drug, itraconazole, to have a suppressive mechanism on extensive or metastatic basal cell carcinoma. This drug first came out in 2012. It was very, very expensive. The price has come down a little bit, but it can be given for palliative treatment for patients with extensive basal cell carcinoma. And there are other drugs that are also biologic agents. These biologic agents are not chemotherapy. They are not chemotherapy. They are biologic agents. They are targeted antibody molecules that were engineered specifically for one specific biologic target. And these are called hedgehog inhibitors. They go to a specific pathway in the development of a basal cell carcinoma, and they block that pathway. So they're very targeted macromolecules, basically antibodies, that attack a very specific link, a site in the pathway to developing a basal cell carcinoma. And patients have to meet the criteria to get these very expensive drugs. It has to be a very large tumor, patient that usually has had previous surgery and the tumor recurred, or the patient's not healthy enough to have extensive surgery. So once they meet the criteria, then sometimes the insurance company will pay for these. And it's quite impressive. Here's a patient with extensive invasive basal cell carcinoma, and then here's after about 6 months of treatment, and this is after 16 weeks of treatment, and you can see the progression of the tumor regressing from this drug being given, and it's given at intervals. And it's taken 1 capsule per day, usually somewhere between 8 and 12 months. It's extremely expensive. It's come down a little bit, but it's still very expensive. There are